Hello, everyone, and thank you for joining our TIF Talk this evening. My name is Lynn McFadden. I'm with Gastric Solutions, and I will be your host for tonight's TIF Talk session. I have the pleasure of having two of our physician presenters here with us tonight. Special guest Dr. Shah, he's a gastroenterologist, and Dr. Kenneth Meredith, a general surgeon, both from Sarasota, Florida. I will take just a quick minute to give you all a brief introduction of both of our physicians, and then we'll start our TIF Talk. Dr. Shah is board certified in internal medicine, gastroenterology, and obesity medicine. He is dedicated to the endoscopic treatment of acid reflux, utilizing multiple advanced therapeutic interventions. Dr. Shah has published numerous papers in peer-reviewed journals and abstracts in local, national, and international conferences, in addition to serving on the editorial board of many journals. His specialties and interests include endoscopic treatment of acid reflux, including transoral incisionless fundoplication, the TIF procedure, and stretta. Dr. Meredith serves as Chief of Surgical Oncology at the Brian D. Jellison Center Institute, as well as medical director for Gastrointestinal Surgical Oncology at Sarasota Memorial Hospital. He has pioneered a number of minimally invasive and robotic techniques for treating gastrointestinal cancers and continues to rank among the highest volume robotic surgeons for esophageal and pancreatic cancer today. In addition to active research, he leads on the safety and effectiveness of minimally invasive tools and treatments for gastrointestinal cancers. Dr. Meredith trains other surgeons in this complex subspecialty and lectures extensively across the world. So thank you both for joining us, and welcome to our TIF Talk.
Thank you.
Thank you.
So you're welcome. So I'll kick things off tonight by just asking one of you to take the lead in giving our viewers a definition of what is GERD.
Okay, so yeah, I can explain that. So basically, acid GERD is gastroesophageal reflux disease, right? And some people call it as an acid reflux. So the stomach has food and a lot of undigested content and the acid. So whenever any of these undigested food or any of the gastric content comes back into the esophagus and it causes the symptoms, sometimes it can go all the way in the upper esophagus and in the back of the throat, and it causes the symptoms, and it is called acid reflux or GERD.
Wonderful. Thank you for that, Dr. Shah. Dr. Meredith, did you have anything else to add to that?
Well, I think it's one of the most common diseases across the country. And I think a lot of patients that have reflux disease, they may experience heartburn symptoms. They may experience some atypical symptoms as well, such as chronic coughing or hoarseness of their voice. It's important to note that left untreated, reflux disease can lead to a lot of serious problems. And the etiology of reflux disease is multifactorial. Mm-hmm. It can be over acid production, it can be hiatal hernia, it could be laxity in the lower esophageal sphincter. So there's a lot of different causes of it. And I think that when you're diagnosed with gastroesophageal reflux disease, particularly from a hypersecretory standpoint and high acid production, you do have options to treat it. But, I think a lot of patients this day and age that have atypical symptoms can be misdiagnosed for a long time, mm-hmm. and, be led to have chronic symptoms without any treatment at all. And then there's also silent reflux, right? So there's a high percentage of patients that will reflux at night and not even know they have gastroesophageal reflux disease. Yeah. So those symptoms typically may wake up in the morning with a sour taste in your mouth or even acid in your mouth. If you have any of those symptoms, it's also really important to not just kind of brush that under the rug as just having, morning mouth, so to speak.
Perfect points to call out both atypical and typical symptoms. It was actually part of my next phase of questioning is, what are the symptoms that your patients are typically presenting with and talking about when they come to see you? Dr. Shah, did you want to expand on that at all as far as symptoms?
Yeah, sure. Yeah, sure. So a lot of people come with, like, just a typical reflux symptom. So, I mean, a lot of them just say that, they have regurgitation and they feel like something, food is coming back up. And then there are some people who say that, they have like acid-like taste in the mouth. So that those two are the most common symptoms. Then, so I basically, divide it into three groups. So the one group of people who has classic reflux symptoms, then the second group of patients who have symptoms of the laryngopharyngeal reflux, where they would feel like, their symptoms are more in the upper part. Like, they would feel like they are coughing, like, they have like, sour tastes in the mouth. And a lot of them, they think that they have a lot of allergies. Sometimes, these people with the laryngopharyngeal reflux, they do have a symptom of typical acid reflux. And there are some people in this category where they don't feel any acid reflux at all. Their only symptoms are the upper symptoms and the throat symptoms. And a lot of time these people, first go to the ENT doctor, and then the ENT doctor does like an indirect laryngoscopy, and then they finally come to us. And, there are some people who have chest pain, like, sometimes they don't have the typical symptoms of the GERD, but they have the chest pain, and, they feel like, it almost feels like a heart attack. And then the last group of patients that we have seen, they don't have any symptoms. So those, like, how Dr. Meredith described, like, those are the people who have like a silent reflux. And I would say that the silent reflux, when the people do have silent reflux, that's really dangerous, because when, they do have symptoms, then they are likely to take the medication. But once they don't have symptoms, they don't even feel it. And then that's why they don't even take the medications. And I have seen many times when we do the endoscopy that the patient has no symptoms, but when you do the endoscopy, they have severe esophagitis and esophageal stricture and ulcers and everything. So basically, I mean, I would divide them into three categories. The number one is the typical GERD symptoms. Number two is atypical GERD, which includes the LPR. And the number three is the people who do not have any symptoms. So yeah, basically those are the three major symptoms.
Yeah, that's a great way of grouping the different types and the different, those folks experiencing those symptoms. And a great call out too, that, you to get evaluated. You're just never sure what's going on. And so it's probably the best approach if you're having any kind of symptoms, to get evaluated. What are your patients doing to manage their symptoms? Or what are you hearing? Or
a lot of them
Right.
come in on proton pump inhibitors, antacids. And like Dr. Shah said, some patients actually come in for atypical symptoms. They've done nothing, and so it's important for those patients to get them on some sort of treatment right away. And then you also have there's kind of a subset of patients that have a concomitant hiatal hernia with the reflux disease. And, it's important to note that just the hiatal hernia, that can be fixed. And fixing that hiatal hernia can alleviate the reflux, particularly, in a younger patient. You don't necessarily want to be on long-term medications for a long time in treatment of this of reflux. So if that's the etiology, you really should consider having the hiatal hernia fix. I know it's kind of moving into, okay, well, how do you treat it? But, in essence, a lot of the patients, by the time they get to my clinic, Dr. Shah has done a significant amount of the workup, and then they're coming in to see me for a surgical opinion regarding the treatment of the reflux, or they've been on proton pump inhibitors or antacids. I had a 40-year-old that's been on it since he was literally 18.
My goodness.
And had a hiatal hernia, and it's never even, no one ever discussed with him, getting his hiatal hernia fixed. You fix the hernia, and they come off the meds, and they're like a different person. And so Dr. Shah and I work very closely, and you need a team, in order to really. Reflux is not a one person, one physician. It is a team approach, and we very much embrace that.
Yeah, I agree with that. Like, a lot of people that we see have like, severe acid reflux symptoms. And I mean, they generally start with some antacids and then they like, go to like, sometimes H2 blockers and then they take Pepsid. And then once that doesn't work, then they start like omeprazole. And, then if you talk to some of these people when they come to us, they are in their 60s and 70s, and sometimes they are young, but especially I see that with the older people that, they will tell you that I have symptoms when I was 20. And like, a lot of the times, they try one and that medication doesn't work, and then they go to the other, then they go to the other, that, they start with the H2 blockers, then they go to omeprazole, then pantoprazole, then Nexium, then Daxilent, and then it comes to the point when they are doubling up the medication and nothing is working. So, and somehow, like, people just think that the only treatment of the acid reflux is taking the medication, and a lot of them will tell me that, I went to my regular doctor, they just told me to take the medication. When one doesn't work, then they tell me to take the other one, and then they go to the gastroenterologist, and it's the same thing. A lot of the people say that, even their gastroenterologists just tell them the same thing, that, just keep taking the medication. And like, so if you talk to a lot of these people, they are really suffering, and then they say that, I have to sleep with the bed elevated, and some of them are like, they have completely changed their lifestyle, that they don't drink alcohol, like, they can't go for Italian food. So there are a lot of symptoms that, it is, and sometimes, it just becomes a part of their life, and then life becomes so restricted that, they have to go and do such a strict grocery that, they don't get the reflux. So yeah, I mean, the symptoms can be really bad sometimes. Yeah.
Yeah, and the ways they're choosing to manage it. And a lot of folks don't really understand the indication for those PPI medications. I mean, what does the package insert say about the indicated use? Isn't it a 2-week regimen or
Right.
something?
Right. And a lot of them have been on for years. And like,
Sure.
if you ask them, like, do you have any bone issues? You know, I find it a lot of times, especially in the older people and especially the older women, if, I have seen it a lot of times that they are on PPI for 30, 35, 40 years, and, they have osteopenia, they have osteoporosis. So, that's kind of like one of the side effects that they get. So, I mean, yeah, it is a real problem.
And more importantly, people haven't discussed that with them. They come in, like I had that discussion the other day in clinic, and they're like, what do you mean I can have bone loss? Like, you've been on it for 15 years, so no one's ever brought that up. No. Okay, well, then you need to get, worked up for osteopenia.
Yeah.
But it's interesting, in our patient population, we actually see a fair amount of patients that are just put, like Dr. Shah said, on a medicine, which in my mind, yeah, they have their place, but it's almost a band-aid,
Yeah.
so to speak. It's treating the symptoms. It's not really treating most of the time the underlying etiology.
Yeah. That's a good point. You talked a little bit about getting worked up. Can you talk about the tests that are used to help folks get a diagnosis of GERD?
Yeah.
Right. Yeah. So most of the time, like a GERD, I mean, most of the time, if they have typical symptoms, just by how they are describing, we can say that, they have an acid reflux. But we at least, if somebody has an acid reflux for a long time, we at least do an endoscopy to make sure that they don't have Barrett's esophagus, or they have not developed like a severe esophagitis and like not a cancer and everything. So basically, endoscopy is the gold standard. But many of the time, in 50% of the patient, even if we do the endoscopy, we don't see any esophagitis, but patient still has the symptoms. So we end up doing like a Bravo. So Bravo is a 48-hour pH testing. It can be extended for 96 hours. So after the endoscopy, I pass a small catheter from the mouth that has a small capsule, and we put that capsule 6 centimeters above the junction of the stomach and the esophagus, and that is wirelessly connected to the monitor. They take that monitor home, and then they, depending upon how many hours we have decided, we either do it for 48 or sometime in some cases 96 hours, and that would tell us that how bad is the acid reflux. And there are some people who have atypical symptoms like a cough and chest pain. So we tell them to, press the button when they have the symptoms. And then, with the graph, we can even see that, how much their chest pain or how much their chronic coughing is related to the acid reflux. And so that's one way of diagnosing it. And sometimes, if we did the endoscopy before and, at that time we did not do the pH testing, then we do 24-hour pH impedance, in which, the nurses at the hospital, they pass a small catheter from the nose, and then they leave that catheter in for 24 hours. And, that tells us that, how bad is the acid reflux. The advantage of the 24-hour pH impedance is that, you can see the acidic and non-acidic reflux. If we have to do the Bravo, which is internal and which is at the time of the endoscopy, we'll have to take them off the medication, like at least the PPI 5 to 7 days before. But, if the patient tells us that, we cannot, I cannot stop taking PPI because my symptoms are so bad, then, we would probably just do the 24-hour pH impedance and see how much is the acidic and non-acidic reflux. So those are the two major symptoms. If somebody has a grade 3 esophagitis, then we don't even need to do any kind of pH testing, because we already know that their bad esophagitis came from the reflux. So basically, that's the pretty much thing that we need to know. And if we ever decide to fix it, or if the patient is interested in the treatment of the GERD, then we either consider manometry or endoflip, depending upon what they want. The manometry is a little more comprehensive test in which we can see the contraction of the esophagus and the pressure inside the lower esophageal sphincter. And then there are some people who tells us that, I cannot tolerate the manometry from the nose. And in that case, if they do not have a significantly big hiatal hernia, then I can do the endoflip at the time of the endoscopy. It's like, passing a small catheter with the balloon at the end, and we inflate it. And once I inflate it at the GE junction, I can look at the pressure inside the esophagus and also the diameter and distensibility. And to some extent, I can even take a look at the contraction. So that tells us that, the esophagus is healthy and they don't have achalasia or something, which is a contraindication for the surgery. So, pretty much those are the tests that, we do for the acid reflux.
And it's important to note that with Dr. Shah, manometry is integral, particularly if they're wanting either their hernia fixed or a surgical approach or a hybrid procedure, because we need to rule out other potential causes, because you can have some patients that may have reflux type symptoms, but they may have other etiology within the esophagus, such as what Dr. Shah mentioned, achalasia or diffuse esophageal spasm, which would alter the treatment a little bit compared to the standard treatment for reflux.
Yeah, thank you for both giving those thorough explanations. We're often asked a lot about the the workup, what's involved, and what will I be going through when I have each of these tests done. So it's really important for patients to understand what they'll go through and what some of those options might be. Let's say they don't get a diagnosis. What could unmanaged GERD potentially lead to?
Well, there's a lot of smaller issues, and then there's bigger issues. So the esophagitis, stricture of the esophagus, difficulty swallowing, those are kind of some of the, smaller issues that are easier to manage. And then if it's untreated for a significant amount of time, it can lead to Barrett's esophagus and ultimately esophageal adenocarcinoma. And if you think about it, in the last 3 decades, esophageal cancer is the largest rising or has the largest increase in cancer amongst all groups. And all of that's attributed to the rise in reflux, the rise in Barrett's esophagus, and more importantly, untreated reflux disease. And so, I always tell my patients, if you've got reflux, I don't care what age you are. I just had a discussion at the gym the other day with another physician whose son actually is, has in college, and he has significant reflux. And I'm like, You got to get the workup done. He's young. You don't want that to be something that he has to live with, until he gets our age. So
Yeah.
I would say that untreated reflux is very, very dangerous.
Thank you for that. Dr. Shaw, anything to add?
Yeah, no, I really agree with that. Untreated reflux is causing a lot of problems. And lately we have been seeing a lot of people with the esophageal cancer. And, a lot of those people who have cancer, they are more and more coming up with silent reflux. Because, if you ask them that, did you have the reflux? They said that, yeah, maybe I had reflux when I was 20. But then, for last 30 years, I did not. So that's why they never got the endoscopy. So that is, I think, a rising problem that we have seen. And I think all the gastroenterology societies are also coming up with the same thing, that we should screen more for the esophageal cancer, because a lot of people has silent reflux. So yeah, I mean, yeah, so yeah, I mean, that is a real problem. And I mean, I think whoever has the reflux, or even at some point, they should consider at least some kind of endoscopy or something, or or when they are getting a colonoscopy, it could be done both at the same time, and at least in that way we can make sure that they don't have a Barrett's esophagus or anything like that.
Yeah, because otherwise, what would drive someone who's not experiencing symptoms to come see you? It's just,
right.
I think that's just an incredibly important topic or part of this discussion. So thank you for that. When we have the diagnosis, can you both talk a little bit about what options are available to treat it, other than the PPI therapy that we touched on earlier?
Well, I can talk about the surgical options, and the big, the bad word in the room, which is Nissen fundoplication. I think it got a bad reputation for many years, mostly because people had chronic swallowing issues, and depending on who does your fundoplication and their volume, the outcomes may not be ideal. We now know that a partial fundoplication, which is either 180 or 270-degree wrap, is as effective as preventing long-term sequela of reflux disease as a total fundoplication without the long-term swallowing issues. But really, from the surgical standpoint, from way long ago from Nissen himself, we know that it's really two things that have to be addressed during surgery. You have to address the hiatal hernia, which is basically, everyone has a natural defect, because otherwise the esophagus couldn't get from our mouth down to our abdominal cavity. So we have to fix that defect. So that's step number one. And then and we know if you don't fix that defect or strengthen that up, 50% of patients are going to recur at least. And then we also know that if you do a fundoplication or don't do a fundoplication, 50% will also recur. So you really have to do some sort of wrap with strengthening that cruroplast or crura, the diaphragmatic crura. So, and nowadays I do a lot of robotic surgery. So I do almost exclusively robotic cruroplasties and fundoplications. But more and more we're migrating now to different endoscopic fundoplications, mostly because when we do a fundoplication, we have to do a significant amount of mobilization of the stomach. And when we do it, endoscopically, as long as we can fix the hiatal hernia, which is due the strength of the diaphragm, we don't have to do a significant mobilization of the stomach. So patients are really gravitating, and their long-term effects or long-term outcomes are actually fantastic. I know I've told Dr. Shaw this before. I know which one I'm having if I ever, need that operation, because you just see the results within the patients, and that's the best we can hope for with our patients.
Yeah, so I mean, it's basically either Nissen's fundoplication, and now it's falling out of favor because of as Dr. Meredith said, because of all the things. But then they can do the partial fundoplication, right? Like a door or toupee, and then it's the hybrid C-TIF. where the surgeon fixes the hiatal hernia, and then the fundoplication is done endoscopically. And as he explained, that that decreases the amount of mobilization of the stomach. And the other advantage of that is, rather than wrapping the entire fundus of the stomach, we are just wrapping last 2.5 to 3 centimeter. And so that is the reason at the end of the procedure, with the CTIF, the stomach still looks like it is dome shaped. And because of that, we have almost never seen anyone complaining of gas bloat syndrome, after the CTIF procedure. So basically that's an advantage. And then basically those are all the options. And then the links is around, so that Dr. Meredith can explain a little bit. But these are basically the options. We always start with the diet and lifestyle. If the diet and lifestyle doesn't work, then we start with H2 blocker. Then H2 blocker doesn't work, then they get to PPI. And after PPI is causing the side effects, or even after the PPI they have breakthrough symptoms, then we can do any of these options depending upon what the patient wants.
Yeah, links is is basically a magnetic sphincter. We do them. You have to dissect around the vagus nerve, and then you insert a magnetic device at the lower esophageal sphincter. And the premise behind it is, as you eat food, the magnets will pop open, and as the food bolus goes past, they shut and close. It's another viable option. It is an implantable device, which is, kind of one of the downside of it. And a lot of patients, are a little leery to have an implantable device, but I've put it in patients, and the long-term outcomes are very, very good from it as well. But it does require a little bit more dissection than the standard. Maybe not as much as a traditional fundoplication, but it is an implantable device, which means a certain percentage of people will ultimately have an adverse reaction to it and then have it explanted. I haven't, knock on wood, had to take any of them out, but I think that's really because we do due diligence in size in the esophagus, because these come in different sizes, and you need to make sure you have the right size for the right esophagus. You put it too tight, they're going to have chronic swallowing issues. You put it too loose, their reflux is not going to be fixed. You have to be very diligent about how you size those things.
Yeah. And I think it's great that, as a reflux program, there's something for everyone. And so I think just being able to come in and have the conversation with the patient as far as what their options are versus just having one. So you kind of alluded to that, the Nissen being the option, being around for so long. But now there are some procedures like the TIF procedure entering the market, years ago, endoscopically treating this disease as well. So thank you for clarifying those. When you talk about outcomes, is that something that you hear typically is the draw for your patients to opt for having the TIF procedure? Or what would the biggest draw be for the TIF procedure in your practice?
Well, I personally think that the biggest draw is they know that, a lot of them are very educated.
Yeah.
And they know that, well, if I can have this done, have my hiatal hernia fixed, and, decrease the amount of mobilization that the surgeon's going to have to do in the operating room and the abdomen, and then get it done endoscopically, but have great long-term outcomes. I think that's kind of the biggest selling point.
Okay.
Dr. Shah, I'd like to, because we've done a lot of these together, and I mean, it's one of those things that you're glad that this approach came about, because it wasn't always, for larger hiatal hernias, it wasn't always, we weren't able to do this kind of procedure, but now being able to do the hybrid approach has really expanded our ability to offer endoscopic fundoplication.
Yeah, and treat a broader patient population, I would imagine, as well. Dr.
And
Shah,
we don't really, because as long as I can get significant length at the G junction or intra-abdominal esophagus, and that's been kind of the bane, so to speak, we usually don't have an issue with that robotically. So we can do these on fairly sizable hiatal hernias, which will be a contraindication for just the standalone TIF, right? So you, like you said, expanding that to a much broader patient population is fantastic.
Yeah, that's excellent. How about you, Dr. Shah? Do you have some additional comments there?
Yeah, so that I definitely agree with. I think, when we work together, we can treat like, broader, like, a patient population. So, like, if you ask the gastroenterologist, most of the time, like, the people who are generally not treating the reflux, they really don't pay that much attention to the size of the hiatal hernia and the hill grade of the hiatal hernia. So that's why, we have seen many times that if patient had an endoscopy done with someone else and they said it was just a small hiatal hernia, but when I just go inside and retroflex and, let the stomach be completely full, then I can see that whatever they said it was a small hiatal hernia, it was almost hill grade 3, and sometimes I have seen even hill grade 4 hiatal hernia.
Wow.
And anatomically, like, for any reflux, we have to think about two things, right? One thing is the size, that means the length and the width of the hernia, which is the hill grade, and like, what happens to the angle of the His. So, when the angle of the His is more, like it's more, then the people get more reflux. And that is the advantage, that when we do a hybrid procedure, like, we can restore the hiatal hernia first, and that's why we get the better results and better longevity. And a lot of these people have no symptoms right after the procedure. And I think, before we started, like many years ago, people were really afraid to even talk about the reflux, because they always have heard some horror story about Nissen going wrong, or like somebody having trouble swallowing. And that's why they are like, if it is that bad, I don't want to go for a major surgery. But as, like, the time is passing and CTIF is becoming more and more common, and the people are becoming more aware, and then they saw that their friends had the procedure done and they did fine and they didn't have any problem, then people are becoming more and more open. Then they talk to us that this is the problem, and then this is what we need to go for. So, and basically, I mean, it's when we work together, we get the better results. We minimize the side effects of gas bloat syndrome, and almost no one gets dysphagia. So I think that helps a lot of people. And I think we have seen over the period of years that people are getting more and more comfortable, like, going for these procedure, because they know that the side effects are not as bad, and the symptom control is equally good, and it's long lasting. So yeah. And then yeah, so that is basically, like, the patients are becoming more and more comfortable.
Very nice. Thank you for that. And I think it really speaks to your partnership and that multidisciplinary approach to managing this disease. It's a team effort, and these patients are very fortunate to have you both involved in their care. Can you talk a little bit about recovery after the TIF procedure? What is that like?
Yeah, sure.
Postoperatively, there's really not a lot from the surgical postoperative standpoint. They have just basically a few pinky size incisions from the robotic ports, and no big giant cuts. They're all absorbable sutures. I let my patients go back to normal activities usually when they feel up to it, and that includes going to the gym. And the biggest thing is we have a very stringent diet protocol. And Dr. Shah and I have agreed on this. And we do it for a reason, and that's why our patients do so well. And I'm going to let Dr. Shah talk about how we manage the diet.
Yeah, sure. So yeah, I mean, basically right after the surgery, we keep the patient in the hospital overnight. And then the next day, we just do the gastrograph and swallow and make sure everything is all right. Once that is done, we start them on like a liquid diet. For first 3 days, they are on strictly liquid diet. Then after 3 days, they can add some little bit of solid, more like, the puree diet. Like, they can eat some baby food, they can eat some mashed potatoes and everything. That's up until 2 weeks. At 2 weeks, I tell them to start some low residue diet and just a little bit of solids. During the entire time, I just tell them to eat like a small quantities, but multiple times, drink a lot of water in between, and make sure that, they wait in between they eat. And then at 4 weeks, they eat and add a little bit more solids. And at 6 weeks, they go back down to completely normal diet. And I think, the reason behind that is, the way in which, these sutures work is by serosal fusion. So, the stomach and the esophagus, where we have taken the sutures, they need to go together, and then eventually they both will fuse, and that takes about 8 to 12 weeks. So we generally, if we keep them on the diet for 6 weeks, it gives them enough time for the serosal fusion to happen. And once it happens, it lasts for a long time. And I generally tell them they can go to the gym and everything, but just don't do anything like they can use their shoulder strength, but they should be able to use their arm strength and do the legs and everything. But I generally tell them not to do anything, which requires a lot of shoulder strength for at least 12 weeks, so that at least the suture becomes more mature.
Yeah, giving it time to really heal and reinforce. It's like anything else, it's baby steps, any procedure in recovery. But it sounds like that diet is pretty significant in the patient having onus in that as well afterwards.
Right.
Well, that's wonderful. Thanks for explaining that. So after the TIF procedure, what are you hearing? What's it like when these patients come back and they have a GERD-free life? What are you hearing from them? What's it like living life GERD-free?
Well, we have kind of all different. We have the people that are the patients that basically say their life is 180 degrees different. They didn't realize how bad the reflux was until they weren't refluxing.
Sure.
And those are the more extreme cases. Those patients are basically, a lot of times they're in tears because they really didn't realize how bad. It's like Dr. Shah alluded to earlier. So these patients come in, they have food aversions. They avoid, they used to eat a lot of different foods, and then they find out that, they've given the things in life that they enjoy, they've given it up for years and years, and all of a sudden they're back to doing that. When you see them at 3 months, they're usually different people.
That's awesome. It's got to make you feel so good to hear that and hear those success stories. How about you, Dr. Shah?
Yeah, it's the same thing. A lot of people would say that, I have seen some extreme cases when people have gone on to completely acid-free diet. And those are the people who start eating after 2-3 months. And, then they are like, I'm fine. Now I can go to the Italian restaurant. So at least, they are happy. And then a lot of people will say that, now I don't have to, wherever I go, I don't have to run to the grocery store to buy something.
Yeah.
I can, easily travel and eat whatever I want. So at least that's a good thing. And a lot of people have told me that they are not using the elevated bed anymore. So yeah, I mean, we have I think almost all of our patients which we have done together, they are off PPIs. I mean, some of them might be taking maybe H2 blocker as needed, a here and there, a once a week or so, but nothing how they were taking before. And a lot of people who would say that they were not able to sleep and they had chronic cough and all those things, a lot of those symptoms gets better. So yeah, it really does help them.
That's awesome. It's so great to hear those outcomes and that your patients get to share that joy with you and keep you part of that discussion. If you were to give anyone who's on the fence advice about reflux, getting it evaluated, getting it treated, what would that advice be?
Well, I think if anyone has reflux, they need to seek, at least go to their primary care physician and just insist on getting a workup. I would say, and I've said that to many people just in the hallways here at the hospital. And because this is, like we talked about earlier, this is something that left untreated can really lead to a lot of untoward effects. And so my take-home message would be, if you've got reflux, get it worked up, get it evaluated, see what your options are. We've talked about a lot of them today, and just know that you could have a different reflux-free lifestyle.
Yeah, I mean, I would agree with that. If the reflux is not that bad, then I mean, then there's not much to worry about. But when it gets to the point that you have to take multiple medications doesn't work, you have to completely change the diet, then at least, they need to talk to either the regular doctor or a gastroenterologist or a surgeon so that we can advise more workup. And then depending upon their symptoms, we can come up with the individualized plan that, what we could do. It's not always the surgery. I mean, sometimes, the reflux is not that bad. And in that case, they can just get away by taking like H2 blockers, like, Pepsid. But at least it needs to be treated, because otherwise, if somebody has a reflux for 30, 40 years, that can cause like a strictures, that can cause the cancer, and this is completely avoidable. So at least, if they can, seek the treatment, we can give them the plan according to their needs, and, that generally works out for them.
Excellent. So the message is get evaluated and see what's going on. And there's a treatment out there for everyone. So I want to thank you both so much for being on this event tonight, just to talk about this disease and how it's impacting your patients, how you're managing this in your practice. So thank you for sharing your expertise.
Thank you so much. Thanks for having us.
Yeah, thank you.
Absolutely. And to the audience and our viewers out there, I want to thank you all for joining. And I just want to point out to you, we do have a website. It's a consumer education site. It's called gerdhelp.com. If you're not in the Sarasota, Florida area, close to Dr. Meredith or Dr. Shah, you are able to go on our physician finder out there and find a TIF trained physician in your area. There's also an opportunity to download get instructions to download our mobile app. It's a great tool and resource for you. It's available to download, and you can enter your symptoms in there daily. You can watch videos. There's a ton of educational resources. So please take advantage of that and use it. And thank you again, everyone, for joining us tonight. We hope this was an educational session for you. Please share it with your friends and family, and it'll live out on our YouTube channel and our Facebook page for perpetuity. It'll be out there forever. So thank you again, everyone, and good night.